Hello, this is Debu Tripathy, Editor-in-Chief of Cure Magazine, and I'm reporting from the 32nd Annual Miami Breast Cancer Conference. We're covering a lot of material at this conference. This is a wonderful assembly of experts that are presenting data to a large audience that includes medical, surgical, radiation oncologists, geneticists, and many other disciplines. I want to update you on some of the medical therapies, or medical oncology as we call it, topics that were discussed today and where the field is going. What I want to cover that was discussed at today's meeting is hormonal therapy, which is very important. For early stage breast cancer, we know that for 2/3 of the cancers that make the estrogen receptor, so-called estrogen receptor positive or hormonally responsive, those cancers can be treated with hormonal therapy in order to lower the risk that the cancer may return. In many cases, even years after surgery, cancer cells that may have been left behind can spread, and we know that medical therapies can lower the risk of recurrence. Hormonal therapy is one that we use in over 2/3 of patients, and how we use hormonal therapy has evolved over the years. Tamoxifen, which is a drug that blocks the effect of estrogen on the estrogen receptor and diminishes the tumor drive that estrogen causes on breast cells, has been around for 40 years. We now know that the optimum duration of tamoxifen, initially it was tried for 1 year, then 2 years, and then 5 years following surgery, that 5 years appear to have really been the best period of treatment, and that's what we used for several decades. However, we know that even after this 5-year period that some patients can develop a recurrence. So studies of longer duration of tamoxifen were finally started over 15 years ago. And these studies finally have been completed. It takes a long time to do these studies because you have to follow patients for over 10 or 15 years. But what they show, though, is that 10 years compared to 5 years of tamoxifen does lower the risk of recurrence by another 4 to 5%. However, in patients that start off with very low-risk tumors, for example, stage 1 tumors, which are less than 2 centimeters with negative lymph nodes, for those patients, the additional benefit of 5 extra years of tamoxifen may be so small that it may not be worth the side effects that some people may have. And there's also a very small risk of uterine cancer, which is higher in the patients that take it for 10 years instead of 5. So it is an individualized decision, and we feel that for patients that are still premenopausal who've completed 5 years of tamoxifen, that another 5 years may be indicated, especially if they have a higher risk cancer, stage 2, stage 3, in that range. And so this has really become a new guideline that we're adopting. And then the other area of hormonal therapy that I want to discuss, again for younger patients who are still menopausal, is whether or not shutting the ovaries down with medical therapy, which is a monthly injection, adds anything to tamoxifen. Tamoxifen has pretty much been the standard hormonal therapy. And we use that in patients, in the higher risk patients, they also get chemotherapy. They get chemotherapy followed by tamoxifen. And the question there has been, what about suppressing the ovaries? Because that lowers the estrogen level, and in combination with tamoxifen, does that add anything? And so a very large study called the SOFT and TEX trials, these are 2 studies that were done and analyzed together, looked at that specifically. The SOFT trial in particular compared tamoxifen alone to tamoxifen plus a monthly injection to shut down the ovaries. When you look at the overall study, it did not show a clear benefit from shutting the ovaries down, but if you start to look at subsets of patients, particularly the ones that received chemotherapy that had a higher risk of recurrence, those patients did benefit. So at this conference, we discussed different cases and how we would discern those patients who we may want to add this therapy to. And for the most part, it's going to be patients with higher risk cancers, patients with positive lymph nodes, patients whose risk was high enough to need chemotherapy, and also patients that are very young, under the age of 35. So those are the current groups of patients in which we think adding ovarian suppression to tamoxifen would be important. I will be reporting more updates over the coming days, so stay tuned. Thank you.